Hello everyone and welcome back to our channel. In this video we will talk about aortic valve stenosis. These are the topics that we will be talking about in this video. The normal aortic valve is a three-leaflet structure that separates the ascending aorta from the left ventricle. During contraction of the heart, the aortic valve typically opens 3 to 5 square centimeters. Causes of aortic stenosis can be classified into 3 groups. Firstly, into congenital causes. Secondly, it can be due to calcification. And finally, as a complication of rheumatic fever. This shows how an aortic valve stenosis looks due to rheumatic fever. Generally, aortic stenosis is often accompanied with mitral valve stenosis. This table shows the different ages of onset of symptoms related with each etiology of aortic stenosis. Take a look and you will notice that aortic valve stenosis due to calcification generally presents its symptoms after the 6th decade of life, but congenital causes presents much earlier in life. Now let us talk about the pathogenesis of calcific aortic stenosis. Take a look at this picture. First, the inflammatory cells infiltrate across the endothelial barrier and release cytokines that act on fibroblasts to promote cellular proliferation and matrix remodeling. Next, LDL is oxidized and taken up by macrophages to become foam cells. Also, a subset of myofibroblasts differentiate phenotypically into osteoblasts. And finally, these cells will actively produce bone matrix proteins that allow the deposition of calcium hydroxyapatite crystals. These are some possible risk factors that predispose to the development of aortic valve stenosis. When the aortic valve becomes stenotic, resistance to systolic ejection occurs and a systolic pressure gradient develops between the left ventricle and the aorta. This outflow obstruction leads to an increase in left systolic pressure. Initially, as a compensatory mechanism to normalize left ventricular wall stress, left ventricular wall thickness increases, producing concentric hypertrophy. At this stage, the chamber is not dilated and ventricular function is preserved, although diastolic compliance is reduced. A large transaortic pressure gradient may exist for many years without a reduction in cardiac output or LV dilation. Increased left ventricular mass, increased systolic pressure and prolongation of systolic ejection phase. These 3 factors increase the myocardial oxygen requirement. The 3 cardinal symptoms are chest pain or angina, syncope and dyspnea. But as the disease progresses, the patient will develop symptoms of left-sided heart failure, and as the progression continues, the patient will develop right-sided heart failure symptoms. Make note that these symptoms generally develop at the later stages of aortic stenosis. Physical findings during auscultation of the heart involve a splitting S2 sound. This is because the aortic valve closes after the pulmonic valve in aortic stenosis. And the other finding is the ejection systolic murmur that can be heard shortly after the S1 heart sound. The characteristic feature of this murmur is that it radiates to the axilla. The key findings on transthoracic echocardiogram are thickening, calcification, reduced systolic opening of the valve leaflets and left ventricular hypertrophy. The valve gradient and the aortic valve area can be estimated by Doppler measurement of the transaortic velocity. Thus, the classification of aortic stenosis can be a measure of the aortic valve area or the pressure gradient that exists between the aorta and the left ventricle. In advanced cases, ST segment depression and T-wave inversion in standard leads 1 and AVL and in left precordial leads are evident. Chest X-ray may show left ventricular hypertrophy as shown by the red arrow. Treatment for aortic valve stenosis depends on the severity of the condition, whether the patient is experiencing signs and symptoms, and if his/her condition is getting worse. Surgical treatment is generally recommended for patients with severe aortic stenosis, who are symptomatic at rest and whose ejection fraction is less than 50%, and patients who have a bicuspid aortic valve. TAVR or transcatheter aortic valve replacement is generally done through the femoral route and is performed in high surgical risk adult patients. There are two available systems, one is the balloon expandable valve and the other, self-expanding valve. Thank you for watching. Like and comment. Share this video. Also follow us on Instagram. The link is in the description box below. Make sure to hit the subscribe button to be updated with new videos.